So this is the Duke Cooperative Cardiovascular Society. So it's really an amazing organization that we work to support our current fellows, those transitioning to their first job, and then keeping in touch with our alumni, both through clinical research as well as continuing medical education and other opportunities. So it's been a great opportunity serving this organization. And one of the things that we've been excited about is really increasing knowledge about the organization and additionally raising funds for fellow support. So we have an ongoing raffle. It's $5 for one ticket, $20 for 5 tickets, and the raffle is for a signed poster of the entire 2016-17 Duke basketball team this year, as well as Coach K, and then tickets to the December 3rd game. And they're primo seats, so and we're working on exploring a couple other seat options as well. But face value is $110. I'm sure you could sell them on eBay for much higher, though we don't encourage that. But please contribute. It's, again, $5 for one ticket or $20 for 5. And we're going to announce that at the AHA reception at 8 p.m. on Sunday night. You don't have to be there to win, and we'll collect your information and mail you the tickets as well as the poster. So thanks. Please contribute. It really is, I think, a great opportunity to support the fellows. Every single dollar goes to fellow mentorship activities. So thank you.
Right back here.
The lady in the green scarf. Okay, great. So thanks, Rob. So today's a historic day, obviously, chance to win primo basketball tickets. There happens to be an election happening, but also, more importantly, we have our first speaker ever from City of Hope in California, Dr. Saro Armenian. He's going to be speaking today about the intersection between cardiovascular disease and cancer, which I know is an area of interest for several of our faculty here. A little bit of background on Dr. Armenian. He is an associate professor in the departments of Pediatrics and Population Sciences, and he directs the Division of Outcomes Research at City of Hope. His research focuses on understanding the pathophysiology and risk factors for cardiovascular complications in long-term survivors of childhood and adult onset cancer, and he currently leads a multi-center NIH-funded randomized controlled trial examining the efficacy and safety of carvedilol for heart failure risk reduction in childhood cancer survivors. He also has a number of ongoing studies evaluating novel strategies for early screening and prevention of cardiovascular disease in cancer survivors. So please join me in welcoming Dr. Armenian.
So good afternoon, everybody. Can you hear me okay? Yeah? All right, so Emily, thank you so much for the introduction, and Tracy, is she here? Tracy for the hospitality, and Marty for the hospitality, and it's been wonderful seeing the campus and getting to interact with some of you, and thank you very much for the invitation. So I actually am a pediatric oncologist by training, and talking to a lot of, I'm assuming, adult cardiologists. So what I'd like to do is talk a little bit about how the paradigms that we have learned and developed within the pediatric oncology world can actually be applied to studying cardiovascular disease in adults with cancer as well too, recognizing some of the differences as well. So some of the work will be in pediatric cardiology, and some of it will be in adult as well too. So we're talking about cancer survivors. Cancer survivorship has been an area that's been an ongoing area of interest for research. Part of it has really been driven by the growing number of long-term survivors of pediatric and adult onset cancer. So by the year 2022, it's estimated that there will be 18 million plus survivors of cancer living in the United States. So this is a very large population. What's even more interesting is when you look at this population, you recognize that the vast majority of them are actually going to be very long-term survivors. So those who are 5 years plus. And traditionally, 5 years had always been kind of this magic number that we'd use for quote-unquote cure, right? So we have 3/4 of them are 5+ year survivors. And so one of the things that we've started to do in pediatric cancer research is looking at trends over time through these large cohort studies and looking at causes of mortality, et cetera. So let's talk in the larger landscape is what are the causes of death in these long-term survivors. And what you see in these two large studies, each about 15,000 to 20,000 patients who are involved, you see that the cancer-related malignancy death plateaus over time as you would expect, right? Recurrence decreases over time. And what you see gradually over time as these individuals get older is that there's an increase in all causes of mortality that are not related to cancer, and these are subsequent cancers, cardiovascular disease, pulmonary disease, and other end organ complications. So clearly, cardiovascular problems, second cancers, these really become the driving issues for this growing population. So the focus today is really on cardiovascular disease. So is it just in the pediatric population that we see this trend? And the answer is no. We see similar trends starting to emerge in the adult oncology world as well too. So this is data from large cohorts of Hodgkin lymphoma survivors. And the blue line is excess mortality. But what is in the yellow line is cardiovascular related mortalities. And what you see over time is the excess cardiovascular related mortality starts to creep up as these individuals start to age. And in the breast cancer world, we're starting to recognize obviously more and more that cardiovascular-related mortality becomes the leading cause of death if you follow these patients long term. So this is a very real problem. So what are the cardiovascular issues that we typically see in our cancer population? We see cardiac dysfunction initially manifesting as cardiomyopathy and developing overt heart failure, cardiac arrhythmias, accelerated atherosclerosis, as well as renovascular complications. So before we study the problem, it's really important for us to look at the magnitude and the scope of the issue, how big of a problem was the burden in the population. So we started to do that in the pediatric cancer survivor population, and we showed, well, quite early on that there's a long latency between the initial cancer treatment and the manifestation of cardiovascular disease. So red is incidence of cardiovascular disease following a diagnosis of childhood cancer. What is important about this curve is that the incidence continues to increase with time so that there's no plateau of risk. But we all eventually are going to develop some form of cardiovascular disease, and the question really is that what is the risk in this population above and beyond that which you would expect in the general population? So this cohort study included siblings as well as childhood cancer survivors. So essentially the same genetic makeup, same family history, same lifestyle behaviors, but the only difference really being the cancer experience itself. And what you see is compared to the siblings, the childhood cancer survivors have anywhere from 9 to 15-fold greater risk of developing severe and what we call life-threatening cardiovascular complications such as stroke, coronary artery disease, and heart failure. So that's essentially over the last 10 or 15 years, we really quantified the severity and magnitude of risk, but we really don't know too much about what is the overall incidence of cardiovascular disease in cancer survivors who are adults, treated as adults. And so there are real gaps in knowledge in terms of the true magnitude of risk over time compared to the general population. What's this risk above and beyond what you would expect based on the background? And what are the specific treatment-related modifiers? What's driving the risk? And we really have not studied what happens to folks 2, 3, 4, 5 years post. So a lot of the earlier studies in adults were able to show cardiovascular disease risk 2, 3 years after treatment's done, but we really had not taken it until past 5 years. So we started studying this in the highest risk population at City of Hope, and these were the stem cell transplant population. So these are otherwise known as bone marrow transplant survivors. We looked at over 2,000 1+ year survivors who went through a transplant between 1995 and 2004 with a median follow-up of 4.3 years. And we showed, similar to the childhood cancer survivor population, that the incidence continues to increase with time with no plateau of risk. But again, the next question is, what is the burden above and beyond what you would expect for the general population? And you see that there is a 4.5-fold risk compared to the general population of significant life-threatening cardiovascular complications. So that's just a very high-risk, high-intensity population that's been treated. A lot of these had undergone through multiple rounds of therapy. The next question was, well, how about the general oncology population, the bread and butter oncology population that we take care of? So for this, we really struggled to find adequate databases and data sources where we can actually look at the population level, the burden of cardiovascular disease. So one of the areas that we're actually fortunate is that we have a health system called Kaiser Permanente, some of you may be familiar with. It's essentially an HMO that includes more than 3 million members. The 10-year retention rate in this health system is more than 70% for cancer patients, which is fantastic, right? So they're getting their primary care there, they're getting their cardiology care there, they're getting surgery care. So all the care is essentially within one system, and they're not even allowed to leave the system except for rare exceptions. So we can capture outcomes such as heart failure incidence, stroke, and myocardial infarction through this established electronic record. So we focused on patients treated in relatively contemporary era, 2000 to 2007, had to have no cardiovascular disease prior to their cancer diagnosis because we're looking at the incidence of over time. And we wanted 2+ year survivors because we had enough studies showing us what the acute toxicities of therapies are. And we developed within this, one of the advantages of having this data set is that you can actually target controls. So you can match them 1 to 2, in this case, by age, sex, and zip code to individuals within the same health system. What this does is that it takes away the disparity in health access, right? So you could argue potentially that cancer patients are more involved with the healthcare system. Their screening is a little bit different. But in this population, the screening is the same, access to care is the same, and the quality of care is the same. So you're not necessarily going to have the disparities in care. So we had 36,000 plus cancer survivors included, and we matched them to 73,000 non-cancer comparison. And what you'll see is that median age, this was an older population, was 62. But they were sex matched as well as matched on race and ethnicity, and median follow-up was up to 10 years, so about 6 to 7 years of median follow-up. And this is what you see, is that the incidence kind of is not too different than what you would saw in a pediatric population. The incidence of cardiovascular disease for cancer survivors here in the blue is significantly greater and continues to increase over time. And in some cases, the curves separate from each other for multiple myeloma, non-Hodgkin lymphoma, breast cancer, as well as kidney cancers, with an incidence ratio of anywhere from 20% or 70% greater in this population, after adjusting for well-known modifiers, including cardiovascular risk factors, et cetera. So there is a problem in this population. Then the next question is that, does that impact outcome? Well, when you look at patients within the cancer survivor group, and you look at overall survival in a population who never developed cardiovascular disease versus the population who develops cardiovascular disease, you see a substantially worse overall survival in the population that develops cardiovascular disease, as you would expect. Again, and adding an additional chronic health condition, especially something like cardiovascular complications, could significantly impact your ability to retreat or consider alternative therapies if someone were to relapse. So this is all-cause mortality, about 65% increase in risk. Then the next question we kept getting asked was, well, how does this compare in terms of the overall survival trends in the healthy controls, or non-cancer controls? And so these are the two curves for overall survival in this cohort for the non-cancer comparison without CVD and the non-cancer comparison with CVD. As you would expect, mortality is worse in individuals who have cardiovascular disease. But the big question is, what happens to patients? How does this compare to in the cancer survivor group? And what you see quite clearly is that cancer survivors with cardiovascular disease have this double hit, right? So you have not only just the underlying cancer, but you also have the cardiovascular disease. So this is the populations at highest risk for what we would consider premature mortality. This is sort of the big picture, right, in terms of what exactly is happening. So this is a population that carries a high burden of morbidity and is worth studying. So what drives the risk? So there have been a number of studies now, and we know some therapies that you give for treatment of cancer substantially increase the risk, and some of these have been described for quite some time. So anthracycline chemotherapy, anti-HER2 therapy given for breast cancer. There are some emerging data regarding TKIs and angiogenesis inhibitors, and then in some cases BCR-ABL inhibitors, and then chest-directed radiation therapy. So all of these have different effects on the cardiovascular system. So anthracyclines, the chemotherapy that is really the backbone, at least in the pediatric population, the majority of the therapy has been the most extensively studied group of agents. And that's what we'll talk a little bit more about, and that's what we know the most. And I'll spend the next few slides talking about anthracycline therapy. So anthracycline-related cardiotoxicity, there's a direct dose-dependent increased risk in this population. And so this is essentially showing the relative risk compared to low dose. High dose versus low dose, and what you see is that there's generally a threshold around 250 milligram per meter squared, a cumulative dose that you've received, at which point the risk exponentially increases from anywhere from 10-fold to 20-fold. So clear dose-dependent association, a threshold around which we think the risk is substantially greater, and putting you at risk to be considered a high-risk subset. So obviously this is not just us. Other people have actually shown that there's a clear dose-dependent association between anthracyclines and, in this case, heart failure. But the real question is the clinical experience is, we always get this question of, well, I had this patient who received very high doses of therapy, but nothing happened to them, and I have this patient who received relatively low doses and it developed heart failure. And we looked at our data a little bit closely, and we actually showed that when you look on the x-axis, so on the y-axis is the cumulative dose, you see among the controls in the population that we studied who never developed heart failure, a substantial proportion actually had received very high doses of this chemotherapy drug and never developed cardiomyopathy and heart failure. And then up to 45% of cases received relatively low doses of the drug, but then went on to develop heart failure. So this brings up this question, that you can identify that, for a given exposure, a therapeutic exposure, there's marked variation in the prevalence and severity of heart failure that's not explained exclusively by the clinical risk factors, such as age at which you received the drug, female gender, which had in the past been shown a risk factor, anthracycline dose, and other comorbidities. So there may potentially be genetic risk factors and modifiers, such as inter-individual differences in drug metabolism and transport, generation of reactive oxygen species, how you respond to the drug, and how you respond to the toxic effect of the drugs that may sort of drive the risk in this population. So that was the hypothesis that we wanted to explore. But before we did that, we wanted to actually break down the metabolism of the drug at every step and try to understand how does a normal heart become sort of this dilated cardiomyopathy phenotype. So anthracyclines cause direct myocyte apoptosis through a number of mechanisms, either through enzymatic and non-enzymatic pathways. Eventually, this direct myocyte, if there's enough myocyte injury that happens, there's replacement fibrosis, and then that really starts this process of maladaptive left ventricular remodeling. Over time, there'll be a drop in EF or fractional shortening, classically as a late finding, and then they'll develop heart failure. So if this is the mechanism that's been sort of developed, we wanted to then look specifically at what are the players, what are the proteins along the breakdown of the drug that really modify your response, and what are the genes that code for specific proteins. So we used a targeted candidate gene approach in this situation based on this established model, looking for specific polymorphisms in these genes. And the short answer is we identified 3 specific polymorphisms and 3 genes that were significant independent predictors of heart failure and cardiomyopathy risk in this population, with a risk of ranging anywhere from 2.5 to 4-fold risk. So what are these SNPs? So one is MRP2, which is an important player in the anthracycline clearance via the biliary system, and an inhibition of MRP2 could decrease anthracycline clearance, potentially increase cardiotoxicity. There was also a polymorphism in RAC2, which is part of the NADPH oxidase subunit, which responds to drug toxicity. And then interestingly enough, we found a polymorphism in HFE, which is the gene associated with hemochromatosis, which has interesting implications for a whole number of reasons, which I won't get into too much. But in HFE knockout mice, there's a higher myocardial iron burden and increased risk of cardiotoxicity in this particular population. So we identify these SNPs, we know these clinical risk factors. How can we use that to actually take this information back to our patients and think about drug delivery in a smarter way? So we wanted to actually look at the receiver operating characteristic curves for the clinical risk factors. So this is essentially looking at what is your predictive value if you actually look at the clinical risk factors alone. So you have someone that comes in, you know the dose of the therapy they received, the age at which they received it, some of the established risk factors. Well, the AUC for that is around 0.69, so 69% predictive value. When you look at the SNPs alone, so if you take only just those 3 SNPs, the predictive value is no better than the clinical risk factors alone. But the real money is when you actually combine the two. When you take the clinical risk factors and the genetic risk factors and combine them, and the AUC gets close to that 80% magic number that we really want to see for these kinds of studies. So this really brings up this issue that you know who's at high risk based on clinical risk factors, you know who's at high risk by genetic risk factors. Can you use this information to actually deliver drugs in a better way up front? So if you have 2 regimens, right, with the similar outcomes, but the only difference is really the toxicity that's going to be generated, can you think about doing genotyping and incorporating that information ahead of time? So you can accurately predict up to 80% of the incidence in this population. So why not consider that in our frontline therapy? And that's something that we're starting to think about for our pediatric oncology world. So this is all of you are quite familiar with the modified version of, in this case, the heart failure sort of continuum. So we know that patients are considered stage A, obviously, if they're at high risk, but no structural symptoms. Stage B are those without symptoms, but have structural evidence of dysfunction. And then stage C and D are those with clinically overt disease. And this is specifically focusing on heart failure. So we've done a nice job in terms of characterizing who's the stage A patient. Large epidemiologic studies, genomic studies, whatever it is, we have a good sense as to who is the at-risk population. The real question is, how can you use that information to really develop early screening and interventions to help either avert the onset of stage B or trying to reverse what we consider the cardiac remodeling that's happening. So for that, we think about paradigms for early surveillance and monitoring. And again, we're in a very fortunate position because we know when the injury happens, right? And there's usually a long latency between the initial exposure and the manifestation of disease. So it's not like it's a post-MI population. So we have time to think about public health early surveillance and screening strategies. And how can we use that information and that opportunity to develop new prevention and treatment approaches to help avert stage B disease? So in the pediatric oncology world, we have established long-term surveillance follow-up guidelines. And these guidelines, specifically, I'll keep coming back to the cardiomyopathy and heart failure example as sort of a model how we look at this. So we actually recommend routine echocardiography for patients who are at risk. And the screening frequency with which we actually recommend is annual to every 5 years. And that risk is driven by the age at which, the frequency is driven by age of treatment, radiation dose, and then the dose of chemotherapy and or radiation that you actually received. So it's every 1 to 5 years. But the question really is for us is how frequent should we be screening this population? Is it annually? Is it every 2 years? Is it every 3 years? So the frequency at which is we really don't have a good handle on. And we also recognize that after a while, there's going to be a plateau in potential benefit based on your intensity of screening, right? You could screen someone every 6 months, but is it as good as, are you going to get the same benefit from it as if you're going to be screening someone less frequently? So there's a plateau over time in terms of the new information that you're going to get. And what happens is that if you continue to intensify the screening frequency, the harms and the costs associated with that screening are really going to overtake that. So what the key is to identify that sweet spot, the area where you're getting the maximal benefit from that screening frequency with the minimal harms and costs. And it's not just economic costs, right? So we have patients, for example, who a lot of them will have false positives, will go on through the sort of the psychological burden of having the referrals, follow-ups, additional testing. And for our patients who've gone through a pretty traumatic experience to start with, having them go through that cycle again can be quite difficult. So we have to be thinking about high-value screening. And the question is, well, you make recommendations on screening frequency every 1 year to 2 years to 5 years. And that you try to base on evidence, but we really don't have good data to say that this screening frequency is the best screening frequency for a particular population. And it's also not ethically, or it's not even feasible to randomize large groups of patients to various screening strategies, because by the time you get the information, you'll probably be bankrupt, considering how many different ways you can do it. So we use Markov modeling, and a lot of the Markov modeling that we do essentially is simulating the normal life cycle of a childhood cancer survivor who has been exposed to the cardiotoxic therapy. We have them go through and there are established transition probabilities based on the data for someone going from no heart abnormality to asymptomatic LV dysfunction, et cetera. And in this particular study that we recently published, we ran through 10 million simulations. And that's one of the beautiful things about being able to do Markov modeling. And you can put cost into it and efficacy and try different parameters and to see what your golden target is. And the short answer is that the current guidelines that mandate screening for every 1 to 5 years are cost effective. Effective in the sense that we were able to show that you can reduce the risk of heart failure in this group by 17% at a cost per quality adjusted life year gained of $61,500, which is well below the established threshold of $100,000 to $150,000 for quality adjusted life year gain. So we can show that the current screening strategy is cost effective, but the next question is, can you think about a less intensive screening strategy where you're still maintaining efficacy but at a lower cost? And the answer is yes. You could, for nearly across all these categories, you can go to a much less intense screening strategy, still maintain good efficacy at a cost that is essentially half of what you have with the current guidelines. So we do this now, not just for this particular recommendation, but we use this strategy to look at the efficiency with which we actually make our recommendations. So we know that the current screening regimen is cost effective, but we know that we can make it better. But the next question we always think about is, so we have a population, especially in the pediatric population, where they're going to be living for many, many more decades, right? So is this a lifelong screening? Is there a time at which you can actually stop screening for certain low-risk populations? We don't have a good answer to that, but we actually go to our epidemiology data and show that, and we can see that there are trends. So if you look at the high-risk population, the population that's been treated with high doses of anthracyclines, you see that the slope continues to increase over time. and there's no plateau. So it's what we think is a lifelong risk, and the risk continues to increase, and in some cases, we believe exponentially. But there is a low-risk group, potentially, where there's an increase in risk, but then over time that joins that of the general population or individuals who have not received anthracyclines. So could you, by looking at this data, think about strategies where you may potentially screen the low-risk group once or twice after their treatment is done, if their echocardiogram is normal, then to essentially say you're good, whereas the high-risk population, you continue lifelong screening. So tailoring our recommendations based on the existing data has to be key, especially in the pediatric world. The adult world is very different. We know that based on the limited data that we have, that the incidence curves are not the same as what we see in the pediatric world. We think that for the most part, if cardiac dysfunction, cardiomyopathy, and heart failure is going to develop, it typically would develop within the first year or two after the treatment is done. So the first study is from Daniele Cardinale looking at proportion of event-free patients. So this is patients who do not develop cardiomyopathy and heart failure after breast cancer treatment. And you see for the most part, nearly all of them develop it within the first year. And this is another study that's a large database study essentially showing that the risk associated with anthracyclines plus trastuzumab, the incidence for cardiac dysfunction, cardiomyopathy, is pretty much limited to the first 1 or 2 years. And we have no good data to tell us that the incidence continues to increase over time above and beyond what you would expect for the general population, right? The incidence is going to increase for everybody. But the question is, how does it compare to that of the general population? We don't have that information. So we recently, so this is a report that will be coming up in a couple of weeks that I co-chaired. This is the American Society of Clinical Oncology was very much interested in developing comparable guidelines for the adult cancer patients. So we convened cardiologists, oncologists, and this particular effort was actually, and the guideline recommendations were eventually endorsed by both ASCO as well as the AHA. But we identified key knowledge gaps with regards to long-term surveillance in this adult onset cancer population. We really don't know what the risk of new onset stage B disease is in patients with normal baseline 6 to 12-month echocardiograms. We really don't know the optimal intervention. Right? So in the pediatric world, we have some information in terms of how best to treat stage B disease. In the adult oncology world, patients who develop cardiomyopathy, we really don't have a good sense. We take existing guidelines from the ACC and the AHA and apply it to them, but we really don't know if they're going to have the same level of response. We don't know what the cost effectiveness of different screening strategies are, and we also don't know what the positive predictive value, negative predictive value of echocardiography is by this risk group. So because of that, we were not able to make recommendations regarding the frequency and duration of surveillance in patients who are at increased risk who have a normal echocardiogram at 6 to 12 months. And we use 6 to 12 months because we believe that the majority of these cases are really going to develop relatively early on. So there's the strong gaps in knowledge in terms of identifying long-term outcomes, long-term risk in this population, and accordingly develop guidelines which may or may not be similar to what we see in the pediatric world. So we're talking about surveillance and monitoring. So currently, so we talked about frequency, we talked about cost, and duration. And now the next question is how? How do we monitor them? So the standard, because of convenience, is really to do 2D echocardiography. And in clinical practice, we're primarily focused on systolic dysfunction because that's really essentially what we see for the majority of our patients. But I think as all of you in this room have come to recognize that by the time you see changes in EF, that a significant amount of compensatory ability of heart is actually given way. And a lot of times in my clinic, for example, I'll see someone with normal EFs for quite some time, and then there'll be a dramatic drop soon thereafter. And so one of the areas over the past few years is really for us to try to characterize what is this chronic process that we know is happening in this group. So like I said, we have a long latency. We have the initial exposure and then manifestation of disease 10, 15 years later. So what exactly is happening chronically in this group? At least in the pediatric world, we think that there's chronic left ventricular remodeling that's happening that's characterized by thinning of the left ventricular wall and enlargement of the left ventricular end diastolic diameter. Essentially, the hallmark of this remodeling is the decrease in the thickness to dimension ratio. So what we think was happening is that we have a thin left ventricular wall, large LV diameter. This results in increase in LV and systolic wall stress, and end-systolic wall stress has really been sort of the hallmark in terms of us characterizing how bad the pre-EF heart looks like. This will result in decrease in LV function, upregulation of renin-angiotensin system, increase in the total peripheral vascular resistance, and then this sort of feeds back into the loop of this chronic remodeling that we think is happening. Over time, if there's enough injury and enough remodeling that's happening, then the heart gives way. So that was the theory, and that was what was been proposed, but it hadn't really been studied extensively until recently when we actually look at this in our pediatric population, and we showed quite clearly that there's a dose-dependent change in these remodeling parameters. So you see on the bottom are the anthracycline doses. You see a dose-dependent increase in left ventricular end diastolic diameter, decrease in wall thickness, decrease in wall thickness to dimension ratio, and then resultant increase in end systolic wall stress. So for our clinical practice, we're actually pushing for some of these intermediate parameters to be used as part of the routine surveillance. And we've actually shown that if you have a good sonography tech and they know what they're looking for, you can actually get these parameters relatively reliably in a general oncology setting, in a clinical setting, and consider that as part of the routine surveillance. So what about strain? So strain has not been studied extensively in the pediatric population, but it has been studied in the adult oncology world, specifically in the context of breast cancer. I'm sure all of you are very aware of what strain is, but essentially, we're looking at myocardial deformation, and you've seen this too. But you can have a completely normal left ventricular ejection fraction, but have a very abnormal strain parameter. And we are currently studying this in large numbers of adult lymphoma survivors as part of an NIH-funded study, and we're showing very similar trends. That you'll have normal EFs, but there will be a substantial proportion, up to a third of them, will have a global longitudinal strain value of minus 16 or greater. So I think that's something that is emerging as a prognostic marker. We really don't know much about what to do with it, but we think that at least during therapy, monitoring using strain may be a reliable parameter for predicting cardiotoxicity, and specifically global longitudinal strain over radial or circumferential. And this is a study that actually looked at the predictive value of GLS compared to some of the other parameters, and you see that the AUC for prediction of who's going to develop drops in EF during therapy was substantially greater with a global longitudinal strain. And it's not just that, it's how do you use this information with clinical risk factors. So if you have clinical risk factors, you have EF, but you can also potentially use GLS as an adjunct, and what you'll see is the best bang for your buck is when you use clinical values, EF, as well as GLS in your routine monitoring of your patients during therapy. We don't know, we still don't have a good answer as to what does a change in strain mean during therapy. We know that it's predictive for LVEF changes or other sort of end cardiac complications, but we don't know if you intervene at that stage, are you going to have a reversal or are you going to be able to prevent the problem? So there's an ongoing randomized clinical trial that is actually looking at intervention versus not in a population with abnormal strain during therapy, the SUCCOR trial. And so the results of that are pending, but until then, this is, at this point, just an exploratory parameter that we could potentially use in our practice, but something that is worth keeping an eye on. The next question I get asked a lot about is, how about blood biomarkers? So the cardiology world has really been at the forefront of looking at cardiac biomarkers, both in the chronic setting as well as the acute setting. I'll skip slides, essentially say that we have not found a single cardiac biomarker that's been predictive of cardiotoxicity, at least in the pediatric oncology world, and there's some debate in terms of the accuracy of predicting cardiotoxicity in the adult cancer world, and this is in individuals who are asymptomatic. So using blood biomarkers purely for predicting cardiotoxicity because of the noise and the variation in this group. So we've done a number of studies, and we really have not, and we looked at troponins and natriuretic peptides and ST2 and galectin and a whole host of other markers as well too, and nothing really, even though biologically it makes sense, we haven't found it. But we've used this as an opportunity to say, okay, let's go on an exploratory run and actually look to see, could we use this as an opportunity to understand disease pathology in this group? Could that difference in the disease biology be driving this lack of finding? So in our population, we focused on the subgroup with very abnormal wall stress, so more than 2 standard deviations above normal. As I mentioned, that's a hallmark finding in our group. And we actually did metabolomics and looked at metabolomic profiling using GC mass spec platform, focusing on 64 pathways and 359 plasma metabolites. And as you would expect, when you look at that many of them, you're going to have some hits, right? So the p-value is simple univariate analysis. We found a whole bunch of metabolites that were significantly associated with this markedly abnormal phenotype. But when you adjust for multiple comparisons, what comes out in our population, this is long-term survivors of childhood cancer, is that you see there's a relative depletion of carnitine in this group, and an increase in essential fatty acids and long-chain fatty acids. So why is this important? It's important because long-chain fatty acids are a major substrate for energy production in myocardium, and carnitine plays a key role in the transport of long-chain fatty acids. And buildup of long-chain fatty acids could cause significant myocyte injury in this group. We've also shown that during treatment, there's sequential drops in carnitine levels that is directly related to the therapy that they're receiving. And in mice models, you can actually see that when you use carnitine in conjunction with a cardiotoxic therapy like anthracyclines, you can actually get preservation of healthy architecture, as you see here, versus what you see here is disorganized myocytes. And then looking at specific markers, so CKMB, again in rats, you see that this is marked elevation of CKMB when you give high-dose anthracyclines, but when you combine it with carnitine, you can actually give preservation of, or a decreased attenuation of the cardiotoxicity in this group. We don't know what the role of carnitine is, but again, this is a classic situation where when you don't have the right markers or the right tools, you need to start thinking about, well, maybe there's a different disease process. Maybe there's a different driver of risk in this group. And can we use this as an opportunity to look at pathways where we can actually intervene? Carnitine replacement supplementation during therapy may potentially be something would be explored in this population. So the next few minutes, I want to spend some time talking about the very real issue of large academic centers versus the community centers. And so where I am at City of Hope, we have the luxury of seeing patients as long as they want to come back and see us. But the reality is the vast majority of our cancer patients are 5+ years out, and a lot of them don't want to come back to the cancer center. And in fact, when you look at the data, and this is data that we publish in our pediatric and in our adult transplant population, you'll see that when you look at healthcare utilization, the vast majority of them are continuing to be seen by someone, some healthcare practitioner. But what happens past that 5-year mark is that there's a dramatic drop in the cancer center visits, as you would expect, right? You're done with your treatment, you're not going to come back to the cancer center. And what you see is in marked increases that there's increase in the care that's being provided by the general practitioners. So primary care practitioners are increasingly providing care for the cancer survivors. And put this on the background of evolving paradigms and how we deliver healthcare, right? So the traditional model of paternalistic model of care is no longer going to be relevant over the coming few years, where you have the patient who's completely reliant on the healthcare provider to receive information, diagnosis, referrals. It's really difficult for patients to navigate between health systems and the social care as well, too. And interventions are usually in response to a physical evidence from the patient. So if the patient's not physically coming and seeing you, you can do all the strain measures you want, all the complex metabolomic studies that you want, but you're not going to get any of that information, and you're not going to be able to intervene. So this paradigm is obviously, as you all know, is changing, where you have an empowered patient-sharing ownership. Patients are informed now, whenever, wherever, access to health records, medical records. And this interoperable medical record makes it very easy for us to not only communicate with the patient, but also for the patient to communicate back with us. And technology-enabled support and self-management has to be a routine part of how we care for our growing number of survivors. So more than 18 million in the United States, and not all of them are going to be seen at the cancer centers. So we have started to make investments in telehealth and telemedicine and how we care, and how we use telehealth to monitor our long-term at-risk population, recognizing that not all of them are going to be able to be seen. So this is an initiative that was funded through, it's a partnership between Caltech and a City of Hope. There's a fluid dynamics engineer who has developed a device where through the carotid pulse wave, they're able to generate the ejection fraction, fractional shortening for somebody, as well as other cardiac parameters. This device is no bigger than what I hold in my hand, and essentially that information is Bluetooth to the phone or iPad or whatever it is, and that can be relayed back to the medical center. I have patients who come in 3-4 hours away just to see me for 15, 20 minutes. That's not an efficient time of use of their time, nor is it an efficient use of my time, especially in a population that needs frequent surveillance and monitoring. So we currently have an ongoing study looking at the sensitivity and specificity of this particular technique, comparing to parameters from 2D strain, as well as cardiac MRI. And we're hoping that as we start pushing the boundaries of how we care for our patients or looking for new paradigms, we can integrate this into routine care. So I talked about surveillance, monitoring, early detection. The key is, what do we do? Right? How do we change the course of disease in this population? How do we incorporate prevention and treatment? So we can think about primary prevention, or we can think about secondary prevention. But I've told you that by the time someone develops markedly abnormal EF or fractional shortening, really it's too late at that point. That much of the change is really sort of more delaying the onset of stage C and D disease. So most of our focus has really been on primary prevention, the use of cardioprotectants, early interventions, pharmacologic interventions, or management of comorbidities. So let's talk about cardioprotectants. So giving the drug during the cardiotoxic exposure. So dexrazoxane has been the one that's been best studied. It's been around the longest. It's a weak iron chelator, has other effects as well too, including topoisomerase activity. It prevents chemotherapy associated myocyte death in vitro. And in the pediatric world, we've run now 3 or 4 randomized clinical trials where we put patients on dexrazoxane plus the cardiotoxic chemotherapy versus not. And we show that it does not interfere with anti-tumor effect. So it doesn't interfere with the chemotherapy's effect. The event-free survival of both arms have been superimposed in all of these studies, telling us that it's actually safe to use this cardioprotectant. We've also shown that you can actually get some acute changes in acute markers such as troponins, et cetera, are attenuated when patients are on the dexrazoxane. And in adults, mostly breast cancer, metastatic breast cancer studies, you show that you can get a clinical improvement in heart failure risk. We have an ongoing study where we're actually bringing back these patients who were randomized on these clinical trials, where we show that it was safe to do this, it didn't interfere with that anti-tumor effect. We're bringing them all back to these centers around the country and doing a comprehensive history and physical examination as well, echo, to look to see what is the long-term efficacy of the dexrazoxane. Because really, when you're going to see the best benefit is really going to be 10, 15 years later when you have averted disease. So this is an ongoing study. We've enrolled close to 140 patients onto this, and we have another 200 more to go. It's funded through St. Baldrick's Foundation as well as Leukemia Lymphoma Society, and is now about to be funded through the NIH as well too. So that's pediatric. How about adults? We get asked this a lot in terms of the use of a variety of medications during treatment to attenuate cardiotoxicity. The short answer is that there's really not been a good strategy during therapy. So we looked at this as part of the ASCO guidelines to see if there's any evidence for using beta blockers, ARB2 blockers, et cetera, for decreasing cardiotoxicity risk. So these are essentially the clinical trials that used a randomized model, because in the past there hadn't been that many. And they were just published. So this is the PRADA study, which looked at the randomization of candesartan and metoprolol versus placebo, and they showed that there's modest attenuation of changes in LVEF in the arm that got the candesartan. But the next study that came up, very similar model, didn't show an effect. So it was kind of a bust study. One canceled the other study out. There's another study. This is the Manticore study, which is looking at ACE, placebo, beta blocker, and again, very modest effects during therapy. Really no hard evidence that interventions during treatment, at least with these classes of drugs, can attenuate long-term cardiotoxicity risk. So that's during therapy. And I talked about how we have a good sense as to who's going to develop cardiomyopathy and heart failure. And you have a large proportion of patients who've already received these agents and these drugs, and they are long-term survivors. So can we think about a strategy of early intervention in the population that's already received cardiotoxic therapies, right? So it's already done. And for that, we really didn't have a good paradigm, at least in our childhood cancer survivor population, to intervene in individuals who, for all intents and purposes, had a normal ejection fraction but are considered very high risk. So there was one study that was done, it was out of France, that actually looked at a high-risk population, so patients with Duchenne muscular dystrophy who go on to develop dilated cardiomyopathy. Patients were randomized, they had normal LVEF, essentially comparable group like ours. They develop a dilated cardiomyopathy picture. They randomized them to ACE inhibitors versus not, and they showed a substantial improvement in overall survival. and the majority of deaths were due to cardiopulmonary failure. So we said, well, we know who's at high risk. We know that just waiting for the EF drop is really not the best strategy. Can we think about an early strategy? And we took this model and actually have developed a study which is through the Children's Oncology Group. Now it's open at 60 institutions, funded initially through Leukemia Lymphoma Society in St. Baldrick's and now through the NCI, where we're randomizing the highest risk population to a low-dose beta blocker at dose-escalating carvedilol up to 12.5 milligrams per day, and then placebo. And so this study is ongoing, and we're hoping that this proactive strategy will help reverse some of the cardiac remodeling that's happening, or if anything, stop the decline over time that we've shown in our population. And then how about management of comorbidities? So the big question becomes, well, you're going to intervene with drugs, or you're going to think about cardioprotectants. Why can't you just manage the risk factors? Why can't, and the first question you want to ask is, so, we know in the general population, for example, that hypertension and diabetes are major players in heart failure risk, et cetera, in terms of what's population attributable risk. The first question we wanted to ask is that, are these cardiovascular risk factors a burden above and beyond what you would expect in the general population? And so we showed this in the childhood cancer survivor study. Compared to the siblings, our survivors have a much higher risk of developing hypertension, diabetes, dyslipidemia, and to have multiple cardiovascular risk factors as they age. So not only are they at increased risk at baseline for developing cardiovascular disorders because of the exposures, but they also have a higher risk of developing these additional comorbidities that really compound the risk. The next question was to look to see, do we see similar trends in adults? And this is in adults, where you actually see a dose-dependent increase in risk with each risk factor that you add. So this is risk of heart failure, stroke, or myocardial infarction. So the black line, the top line, is the incidence with individuals who received, who have multiple cardiovascular risk factors. And what you see is that there's a strong effect, and the highest risk is individuals who have multiple cardiovascular risk factors who also have been treated with the cardiotoxic therapy. So there's almost a synergistic effect in terms of what the risk, the increased risk that you're seeing in this group. We wanted to interrogate this a little bit more. Is it all risk factors? Do certain risk factors drive it more than others? And what we see quite clearly is that really what's driving the risk the most, and this is the risk of developing a major cardiovascular event, is a lot of this is driven by hypertension and diabetes. And this is especially important for our pediatric population because we can think about novel interventions. And in this case, going back to that chronic remodeling process that we talked about, where does hypertension really play into this accelerated remodeling? Well, it's essentially just adding to the increase in the total peripheral vascular resistance that you're seeing at baseline. So potentially aggressively managing someone's high blood pressure could at least slow down, in some case reverse this process of chronic remodeling and hopefully avert the risk of cardiovascular disease. What about exercise? What does the role of exercise play? We can have a whole hour talk on exercise, but there have now been a number of studies that have actually shown that as you increase the intensity of exercise, you increase your risk of any cardiovascular disease risk in the cancer survivor population, as well as coronary artery disease. And in fact, based on this threshold that they used, that there was a reduction in risk by 50%. So simple lifestyle behavior modification in our childhood cancer survivor population, as well as the adult cancer survivor population, could lead to substantial improvements in outcomes. So where are we at? So we know that when we're talking about patient care, that there are certain cancer-related treatments that are associated with their own toxicities, that there are a number of cardiovascular health and risk factors that sort of interplay and have a role in modifying risk. And then there are also unique host and variables such as genomic risk, et cetera, that may modify this risk. How do we look at this problem? Well, I think we need to continue our ongoing efforts, sort of our epidemiologic work and registry research, to identify what is the changing landscape with changing treatments and paradigms over time. In terms of oncology care, do we see different patterns shifting? What is the current state of the oncology clinical trials and how we understand cardiovascular risk detection and in this particular group? How do we image them? How do we monitor them during therapy? And then how do we develop the next generation of studies looking at simple, basic translational studies and clinical research to help us understand the pathophysiology and mechanisms that drives this risk. And in some cases, we believe that there's an accelerated risk. So what's driving this accelerated risk? We need continued efforts in sort of understanding this pre-symptomatic state so that we can develop the prevention and lifestyle interventions as we have done for the pediatric population, and in turn set the stage for guidelines and clinical practice standards, and then disseminate this to the general oncology and the cardiology community, so that clearly this is not something that we're talking about in silos, but something that we're talking across disciplines. And I'm especially honored to be here talking to you at such an illustrious institution, because I think the more we have these dialogues, the more we have the opportunity to come up with some innovative approaches to help mitigate the risk. So I want to end here by acknowledging folks at City of Hope who are in my group, and then collaborators, and here Pam Douglas at Duke, who have been really instrumental for a lot of this, as well as the funding agencies. And thank you for your time and your attention. I'm happy to take any questions that you may have.
So you talked about the shift from management from the oncology world to the primary care and potentially general pediatric setting, and I'm wondering what your thoughts are on whether that is as it should be, or whether, given the complexity and the emerging paradigms around predicting cardiomyopathy risk, that the primary care and general pediatrics is the right setting for that.
So whether that should be the place, or you're saying continue? I mean, I think there are people who have spent their careers studying what is the best sort of model to take care of these folks long term, and so I don't know. Part of it just has to do with there are advantages and disadvantages in both approaches, and I think some of it just has to do with ultimately patient preference and being able to have an adaptable system where you can do both approaches. What I mean by that is that the reality is the vast majority of it are going to be seen by the primary care in the primary care setting. Now, can you go out and educate every primary care provider about what are the issues that cancer survivors, both pediatric and adults, face, and have them store that information somewhere along with all the other information that they have, and then think about the patient that really is only a minority in their larger thousands of patients. So that's a difficult one, right? How do you educate it? So I think the ultimate message really has to be is this communication and the portal with the patient. And so whether or not the patient decides to get their care at the cancer center or at the primary setting, ultimately they have to be aware of what are the things that they can be monitoring for, and actually have to be their own advocates. And I think that the cultural shift will mandate that. And so we have to be nimble enough and come up with, so we can do intensive approaches or very remote monitoring approaches, but at least have both options available if the patients want to. And that continues to be a challenge. But I spend about 70% of my clinic visits just talking to the patients about what treatments they got, what are the issues that we're going to be monitoring for, and then really leaving it in them and in their hands to really take it to the next level. For my pediatric population, I'd say 3 out of 4 can't even tell you what cancer they had. So we just start with just saying, okay, what were you diagnosed with? Let alone what drugs were you treated with? Let alone what are the risk factors, et cetera. So I think, but they're much more receptive to that. It's very tough to engage the primary oncology, the oncology as well as the primary care setting. So it's a long answer to a very, but I think it's just got to be a hybrid approach, I guess. Yeah.
So a lot of the pediatric clinical trials focus on just the 5-year survival with the oncology endpoints as sort of the main thing that the trials are powered on. It seems to me like you're making a compelling argument that we need to have a co-primary endpoint on these trials that are safety, in the same way that we're now evaluating diabetes drugs, and maybe even build in better long-term follow-up. What are ways that you would like to see clinical trials in children change to better improve our assessment and understanding of safety endpoints?
So, so there are so many ways of tackling this. And let me just give you an example. So there was there were 2 large clinical trials that were done in the Children's Oncology Group focusing on patients with AML, acute myelogenous leukemia. This population receives very intensive chemotherapy. They also get sick during therapy a lot. And so the clinical trials reporting is really focused on certain parameters, right? Certain oncologic parameters that and CTCAE grading criteria, et cetera. And so when we looked at the study that was done between 2000 and 2005, the reporting of a simple outcome, you would think, heart failure incidence, right? It was like super low. It was, I don't know, 1% or 2% or something. And then one of my colleagues got a grant where the only thing they did with that grant, which was an NCI-funded grant, but essentially established a standardized way in which all outcomes are going to be captured electronically, consistently, and with a heavy emphasis on cardiovascular and infectious-related outcomes. And almost essentially the same regimen, same drugs, but the incidence all of a sudden went from 1% in terms of reporting to 20%. So the simple things are fixing what you already have, right? The reporting that you're doing. That's just one thing, just pure reporting. Not the least, and then on the other end of it, you have imaging, right? And I'm not as convinced that the imaging parameters are solid enough, at least in the pediatric population, that you could implement them across 200 plus institutions. You may be able to do them across selected institutions. But as strain and other sort of some of these early markers start emerging and being prognostic, maybe there'll be increased acceptance in this group. But that's a very real challenge. And then the big question is, what do you do about it, right? So you find these markers. So is someone really going to pull the trigger and actually do the intervention right there and then during treatment? Put them on the beta blockers, put them on whatever it is that you need to put them on. I don't know. The final thing I'll say is that the more we study this, the more we understand how nuanced some of these things are and some of the inter-individual variation in the germline variant. So one of the simple things we could do is if we can continue to validate some of these genetic association studies, we can actually think about upfront changes to therapy, right? Think about sort of upfront avoidance of certain drugs if you have a comparable regimen that's going to give you the same kind of outcome for certain high-risk populations. So this, and everyone talks about precision medicine, et cetera. But we do that to some extent in our pediatric world because we do tailored interventions based on certain molecular profiling, et cetera. Well, why can't we integrate that with the acute toxicity data as well as the long-term toxicity data up front in our decision making? In the pediatric oncology world, we're very lucky. We have overall survival in some cases reaching 90, 95%. We're never going to design a clinical trial that's going to improve our survival rates above 95% in some cases. You're never going to do that. So then you can start thinking about clinical trials that use novel approaches for risk reduction, and whether it's acute toxicity or long-term, based on some of these risk factors. So, again, a long answer. I get passionate about these things. So we think about this a lot. So, all right. Well, thank you for your time. Appreciate it.